of the House who are here this morning. I'm Tom Prislak, the President and CEO of Cedars-Sinai in Los Angeles, and have the privilege of serving as Chair of the Board of the American Hospital Association, which represents 5,000 member hospitals, health systems, and other healthcare organizations. The people of our hospitals are fully committed to reform because we see every day how good our health system can be, but also how much room there is for improvement. We commend the House committees for taking a major step in this direction by expanding health care coverage for the uninsured. To us, meaningful reform, first and foremost, expands coverage to at least 95% of all those residing in the United States. Achieving this goal requires a shared responsibility among all stakeholders. This includes an individual mandate, employer responsibility, and government subsidies for those who need financial assistance. We acknowledge that 100% coverage is unlikely. There always will be some who fall through the cracks, and we appreciate that funding mechanisms such as the Disproportionate Share Hospital Program are preserved to continue to act as the safety net for those individuals. We applaud that the legislation restricts the ability of physicians to self-refer to hospitals in which they have an ownership interest. As we saw in the June New Yorker article, Dr. Atul Gawande, areas where physician-owned facilities flourish tend to have significantly higher healthcare spending levels. Decisions about a patient's care should be based on what is best for the patient. You have taken a major step toward ensuring that these decisions are not based on financial interest. We're also appreciative that the legislation includes no cuts to graduate medical education, including the indirect medical education adjustment, which helps train the next generation of doctors. That will be critical as reform brings more people into the system. All these issues are key to successful reform, and we applaud the House leadership for addressing them. My written statement has more details, but I would like to point out a few concerns that we do have about some other proposals. We continue to have concerns about tying the public option to Medicare rates. While the bill provides a payment range, it gives the Secretary broad discretion to set or negotiate rates, and we fear that there would be little incentive for the Secretary to pay more than Medicare rates. This could bring significant losses to hospitals as people and employers enroll in the public plan because of its lower premiums, which would be made possible by the existing underpayment of providers. The problem is illustrated by the Medicare Payment Advisory Commission, which projects that hospitals will have a negative 6.9% Medicare margin in 2009, down from a positive 6.2% margin in 1999. That's the lowest level in more than a decade. Our annual survey data reveals that a staggering 58%, or 2,840 hospitals, lost money serving Medicare patients in 2007. That's why we feel strongly that any public-sponsored insurance option should require that provider payments be based on negotiated rates without a link to Medicare payment rates. On readmissions, please know that hospitals are working hard to reduce their readmission rates. But while we agree with the bill's intentions, we do have concerns with its methods. Representing a potential cut of $19 billion, the bill reduces payments to hospitals with higher than expected 30-day readmission rates for heart attack, heart failure, and pneumonia. This cut would apply to all Medicare discharges, not just readmission cases. Preventing unnecessary readmissions is a complex system-wide goal that involves hospitals, physicians, skilled nursing facilities, and other providers who manage patients' care, as well as patients and their families. Policies that provide incentives to reduce readmissions should focus only on unplanned readmissions that are in fact related to the initial admission and for which the greatest opportunity exists for hospitals to prevent their reoccurrence. Finally, the legislation permits Medicare to pilot programs in which accountable care organizations are paid to manage the healthcare of defined populations. However, the ability to provide the leadership of ACOs is limited to physicians or physician organizational models. We strongly believe the bill should allow groups of qualifying providers, including hospitals, hospital physician partnerships, and hospitals employing physicians, to voluntarily form and lead ACOs and share in the cost savings they achieve for Medicare. ACOs offer an opportunity for real delivery system reform, and hospitals and healthcare systems are well positioned to provide the organizational and leadership structure that a successful ACO will need. In closing, let me say again how much we appreciate the opportunity to share our views on meaningful reform and the leadership's work to achieve it. You have our commitment to work with you on reform that truly makes healthcare better for the patients and communities we serve, and that helps us get care to all who need it. Thank you.
Thank you, Mr. Prislak. Dr. Maryland?
Thank you. Speaker Pelosi, distinguished